we don't have any slides or anything fancy. I just want to discuss with the cardiologists here. What's their experience in the community with cardiac amyloid? I know, as a primary care physician, all the, hurdles and all the obstacles that I myself deal with, from prioritizations to, diagnosis, treatment, the relationships that we have with our consultants, etc. So would you guys, like to comment on that? Oh.
Can you hear this one?
Yeah.
Okay, perfect.
Hello.
I can kind of briefly go into that just a little bit about challenges in medicine delivery. I know we don't have that much time, but amyloid is just a small subset of what we do. I'm in Sierra Vista, Arizona, which is technically the largest city in southeastern Arizona, but it's still 40,000 people. The challenges for amyloid care are the same for challenges in COPD care and CHF care and kidney disease care. It's just lack of resources and just being severely medically underserved. So you kind of have to wear a lot of hats and be comfortable doing that. Honestly, my patients have no idea what an interventional cardiologist does. You're just a doctor in the community. You're a primary care to some people, you're a cardiologist to others, you're a pulmonologist sometimes you're a rheumatologist, right? It's whatever you're comfortable being, because your patients don't care what your title is. They care, can you make me feel better? And sometimes, am I trained in doing advanced interventional procedures? Sure, but if I can prescribe a medication to take once a day and make them feel better, to them, that's the same. So the challenge in being a community is, are you comfortable kind of stepping outside of your comfort zone, your silo that you're kind of trained to exist within to deliver that care? And amyloid is just a small subset. So the way I approach it is I rely heavily on my reps, because again, when you're a small community, you don't know who to send patients to, where to order the imaging at, and your reps, the unsung heroes of rare diseases, really don't get enough appreciation for what they do, because they're on the road 24/7. They're logging thousands of miles on their cars. They're eating in the car while driving, and their job is to put you in touch with the right physician. How do you get your program started? And without them, I wouldn't have started an amyloid program. So it took about just under a year to get that going, but without them, I don't think I would have a program.
Okay, thank you. Dr. Yenigalla, any experiences? She's down in Yuma, Arizona, I believe, and she's also an interventional cardiologist. What's your experience down there in Yuma, Arizona?
Yeah, I would like to introduce myself, Dr. Yenigalla. I did all my training here in Phoenix from Banner, and I'm not an interventional cardiologist. I'm an advanced heart failure, heart transplant cardiologist. So yes, it has been challenging for me personally the past, I would say, 5 months that I have been down in Yuma, because when you are in Phoenix and when you are at Banner and you had everything available, right? So I did not have to spend hours trying to get a medication, or I did not have to spend time thinking about, is the quality of my PYP scan good? So, but when I am in Yuma, first, awareness in the community. So we do have cardiologists and who are there for decades, and they're really good cardiologists in the community taking care of patients. But when it comes to cardiomyopathy, especially amyloid, right? The awareness or the understanding is that, yes, it's still a rare disease. And we do have our own plates full here, trying to deal with ischemic heart disease or coronary artery disease, trying to put stents in. Yes, the burden is high, but at the same time, our population, Yuma, has a lot of veterans. And these veterans are more than 70 years of age. So Yuma is an interesting community. So we have about 98,000 to 100,000 patients in Yuma, and then the population swells up to 200,000 in winter. And all these winter visitors come from up north, and they're from Canada. We have a lot of Canadian visitors, We have visitors from Minnesota, Oregon, Washington, and all these states like up in the north, and they belong to smaller towns and countryside. And they don't have access to big academic medical centers where they come from. So they have their summer homes there and then winter homes here. So they stay with us for about 8 months. How do you coordinate care in such a setting when you have a patient who is here for 8 months and then who leaves to go back to their summer home for 4 months, right? So that itself has its own challenges in terms of coordination of care, because as we have been hearing all along since this morning, this is a systemic disease. You do have neurological manifestations. You need to know, you need to have a hematologist friend, you need to have a neurologist friend. And it is easy to deal with the disease when you are in an academic center, but when you are out in the community, you feel like you are alone, you feel like you're solo, and that's where the community comes in, right? Today, I felt after having all these conversations with the cardiologists here and with the industry personnel here that, we have your back. If you want to build something, then we are here to support you in doing that. So what have we done so far in the past 4 months? We tried to get in a PYP scanner, which we did not have prior to August. So I started my job in August, and then we started PYP scanning in Yuma in September. And that itself is a game changer for us, because the first year I want to focus mostly on the diagnostics and now we are able to perform genetic testing in my own clinic. So I see mostly general cardiology, but I have a dedicated time or a day that I am dedicating right now for cardiomyopathies. So I'm able to do genetic testing, and then we have a PYP scanner, and I'm able to also perform heart biopsies because I'm trained in advanced heart failure and heart transplant. So once the diagnostics are set up, and once we are able to identify these patients, then we want to go into the therapeutics realm next year. But this year, our focus is to build up all the diagnostics that we can and then get the program running.
I can only imagine the challenges of having to treat these patients, we were talking about combination therapy in the first lecture, Dr. Stern, you're talking at $750,000 a year, right? Something like that. What are your challenges when it comes to, affordability of those drugs? Of course, now that we have diagnosed the patient.
Hello, everyone. I'm Dr. Natarajan. I'm a early career interventional cardiologist in Sun City West area. So, as you know, it's a retirement community, and most of our patients are above the age of 70. And just to echo what you heard from the other speakers, so amyloidosis, when we are going through fellowship and you're going through training, we somehow get this belief that it's one of those rare entities that we'll come across once in a while. I was proven wrong when I started my practice. I was just talking to some of the other guys here, and in the last year and a half in Sun City alone, we picked up almost 10 patients in our practice, of which 8 came through several other avenues, patients who come from Mayo Clinic, patients who come from Honor Health. So there's a lot of these patients out there who have heart failure with preserved ejection fraction, but they are never investigated further. And I think the awareness that this is not a rare disease, but quite a common one, and it's out there in the community, just has to be picked up, is I think the most important message that has to be out there to other general practicing cardiologists. And then the presentation of amyloidosis is not straightforward. It's not as you would read in a clinical vignette in a textbook. I've had 2 of my patients out of the 8 who came in with recurrent pleural effusions, and that's all there is. They didn't have a very thick myocardium. They didn't have the typical diastolic dysfunction findings on echocardiogram, but they just had recurrent pleural effusions requiring pleurodesis. So it's never that straightforward. There are patients who have heart failure with reduced EF who keep having a fall in EF despite good GDMT. So there are, you got to have a good understanding of the disease process to be able to think beyond your textbook description of your amyloid patient. And obviously, in a busy practice, I work in a private setting where we see anywhere from 35 to 40 patients in a full day clinic. So for us to perform, in-depth extra cardiac manifestation screening is going to be difficult. So that's where the ancillary staff and your advanced providers all come into play. And I think in this time and age, it's almost imperative that every group has a heart failure team and enough resources to manage these patients.
I hear that the common theme is like multidisciplinary approach to the disease, given the manifestations, whether it's cardiovascular, neurologic, autonomic dysfunction, gastroparesis, and whatnot. Any comments, Dr. Lee Chuy, on the market in Tucson? I'm as a primary care, I think awareness is the biggest. So how is you guys' partnership with the primary care community, which I think, it's so important for them to be aware of the disease. Like if they don't know, I recall a couple of years back, I did have a patient admitted to my service in the hospital that he had atrial fibrillation, had spinal stenosis, bilateral carpal tunnel syndrome, was African American. So I actually reached out to the primary care physician regarding the case. I said, I think this patient has cardiac amyloidosis. And he went like, what is that? What are you guys feeling of that?
Hi, I'm Katherine Lee Chuy. I'm one of the interventional cardiologists in Tucson. And we started about our amyloid program about almost a year ago. The main challenges, I think, with cardiac amyloidosis, as you probably all know, is just getting the diagnosis or having the suspicion for the diagnosis. What we tried to do in our group is that we do have some primary care clinics that we partner with. So we would have some, especially when I first started, they would do like luncheons for meet and greet to meet like the new providers in town. And then I would sort of introduce certain particular things that I manage in my cardiology clinic. So we talk about amyloid and kind of give a spiel about different signs and symptoms to look for. It's also like even in general with other general cardiologists, like my partners in my group, it's a lot of times it's just a little, just reminders about, hey, like, I read your echo and, maybe consider looking for amyloid in this patient. Also helps with, as Dr. Fahad mentioned, the industry reps, they definitely connect you to a lot of different practices around town, different cardiology practices and subspecialty practices. So having like a neurologist, go-to neurologist, hematologist, a referral for endomyocardial biopsies, also where to get your MRIs done, since we don't do MRIs in our facility. The nice thing that we were able to do was we were able to start up our PYP, where basically our HMDP scanning in our own facilities. So that definitely shortened the time, the patient's wait times, and at least we know that we're the ones reading or interpreting our own studies, and we can, it's more of like quality control as well, which is a challenge in the community. Everyone coming from like a training program, we all train in a big academic center with all the resources, and you can trust the quality of imaging studies or results that you're getting. But in the community, it's, it's pretty hit or miss. So a lot of, for example, with the nuclear scans, do you take the word of just the results, the written results, or with echoes, even for us training our echo techs to try to do proper strain has been a challenge and is still an ongoing challenge. So I think the other challenging part in our practice is just staffing. We're a private group. It's for profit. The administration is not going to give me like an APP to work with. The whole clinic is ran by me and my medical assistant, who also has to take care of all our other non-amyloid patients as well. So
As a segue of that, last comment, when it comes to treatment, given the cost of these medications, how affordable, how easy is for these patients to get the medication? Any experience in your particular situation?
I can speak for, at least from a Sun City perspective, most of our patients on an average are above the age of 70. So in terms of Medicare coverage, it's actually pretty good. So I haven't had much trouble. The private insurances can be a hit or miss, and you need a good prior auth team and all that to take care of it. But thankfully, the industry is pretty active and forthcoming to take care of those hurdles for offices. So in general, I think getting drugs approved is not a problem. Whether patients can afford a copay is a different conversation altogether.
The other issue that I can think of, for example, I was practicing in a hospital that they didn't have strain imaging for the echo. Will you please comment on that? More in relationship to how is the healthcare system supporting, your therapeutics, your diagnostics actually, from PYP scan to strain imaging, advanced echocardiography.
The way we started strain imaging in our hospital, in our office, you just have to sell it to the administration and say that you do get paid extra, or there's extra reimbursement to do strain. So you kind of had to speak their language to try to get that support. There are resources from the echocardiography industry to help train the echo techs. So that's kind of how we started. We're still working on it in terms of quality control, but.
Do you see any role in this symposium, for example, rather than being in Phoenix, also extending to places like Tucson, Yuma, so we can continue to raise awareness of the disease and, impact those lives that maybe they don't know that, this is what the disease that they have, right? Especially, those are retirement communities like Yuma, for example, Tucson, Sierra Vista. I know there's a lot of snowbirds or winter visitors that, frequent those areas during the winter month. And, I think it's just a perfect setting, for patients that could have amyloid and that hasn't been detected.
That real quick. I think symposiums are great to get a lot of people in one place, but realistically, it has to be at the grassroots level. It has to be small dinners, frequent dinners. And if you're lucky, you get a primary care here, a couple there, some nurse practitioners or APPs. But realistically, you're not going to get a small town like Sierra Vista to have everybody at one event. And again, amyloid is not a cardiac disease. It's a systemic disease. By the time it comes to us, it's already advanced. It's like looking for, breast cancer by imaging the brain. Yeah, it'll get there eventually, but you're not looking for it early enough, right? So for me, the important part is ASNAC, there's so many resources for amyloid, think amyloid. I have those slides all the time. Think amyloid when you have dysautonomia, when you have these weird GI symptoms, when you have, orthopedic issues, you have to think of it early. And you have to keep reinforcing that message over and over, and it has to be at the grassroots level.
Just going to open up for questions from the audience now. Anybody has any questions or comments? That's okay. Thank you all for coming. And I think we're just going to adjourn for lunch. Thank you.